So the folks that were here yesterday for the otology piece and met all these folks, but if we could just start on the far end with Gavi, if you could just introduce yourself and tell us something, introduce yourself and tell us something that you're going to do fun for Thanksgiving weekend.
Gavi Kohlberg here at UW Medicine at Harborview, and for Thanksgiving, I'm luckily, because my huge in-law family in Seattle, I'm only going to drive about 35 minutes and then promptly hand over my children to my sister-in-law and sit on the couch.
Brian Kung. I am working on Thanksgiving, but this weekend we're going to Spokane for my daughter's skating competition. So hope it goes well.
So Brian's daughter is a competitive figure skater. Yeah, and I think her aspiration is to be a starting center for the Kraken someday. So.
Wow, that's amazing. I'm Chad Ruffin. I'm also working on Thanksgiving, but my father's going to be here. And for anyone who knows Seattle, Louisiana is the exact opposite place, so it's always a trip when he's here.
I'm Brandon Isaacson from UT Southwestern Medical Center in Dallas. I am flying on Thanksgiving Day to Connecticut to see my kids.
Excellent. I'm going to get one more chair for Dr. Hume here.
I'll find it. Where is it?
I have no idea. If you ask Corey. All right, so what we're going to talk about, and the panelists will actually be looking at the slides on the videos in front of them. You'll be looking at them up front. But there's kind of an existing paradigm that when you manage chronic ear disease, that the first thing you always do is manage the infection portion of it. And then you come back and you think about, well, what do we need to do from the standpoint of hearing restoration? And one of the things we brought up yesterday is as you're looking at your CT scan, the patient, the audiogram, I know what we do is we actually sit down before surgery and we actually map out how do we want to go about this case to eradicate the disease and give us the best opportunity for hearing restoration. So it goes into the thought process, knowing that we're going to, the fallback is going to be getting the ear safe. But you see multiple people over and over again getting tympanoplasty after tympanoplasty, mastodectomy, tympanoplasty, and finally they get an osseointegrated device, and then they can hear. And the question is, and the question we're going to challenge on this panel is, how do people think about conductive hearing loss, chronic ear disease, otosclerosis, and then at what point does your paradigm shift in whether you use a hearing aid, whether you use a Baja, something like that? So that's kind of the theme of what we're talking about. So this is case number one, and can we put the cases up on the screens for the panelists? This is a 42-year-old male who had a persistent conductive hearing loss after a stapedidotomy. So Brandon, what do you see? You can actually see in front of you now. We put them in front of you. Oh. So what do you see on the CT?
I'm still going to look at this one because I can't see that.
Yeah.
So this patient, this is a axial CT scan, bone windows. Looks like there is cochlear otosclerosis. You can see the kind of ghost or ring sign around the cochlea and even part of the vestibular system. You can also see that the oval window looks fairly irregular at the level of the tympanic facial nerve on the left and on the right, not as much. And so this hearing loss pattern is not surprising. They have a large conductive component, but they also have a significant high frequency component, which is fairly typical of a cochlear involvement with otosclerosis. And so this patient, no matter what you do from a surgical standpoint, is eventually or is a candidate for amplification. But I also do think and you could potentially try to amplify their right ear, but there's so much hearing loss there, I don't know if you would be able to do so without having a substantial amount of feedback. But if you were to do a stapedectomy on them on the left side, then they're still going to benefit from a hearing aid for that higher frequency loss. And same goes with the right ear. If you were going to operate, I'd choose the left ear.
So I'm going to do something really quick. Can we take the panelists and put you at an angle like this? Because I realize they can't see the audiogram and you can't see the big screen. So we'll just do this. Chad, you're right here. Not too far, though, so they can keep you on the screen. We'll make sure we're on the screen. And by the way, all of the lectures, all of the videos, within a week will be on the Seattle Science Foundation YouTube site, so you can watch all this stuff all over again. So the reason I show this is twofold. One of them is this is the audiogram we got. And we asked him to send it multiple times, and it kept looking like that. So make sure you can read the audiogram before you operate on it. And if your audiogram doesn't make sense and your tuning forks don't make sense, repeat the audiogram. So Brian, how would you approach this patient? Had a stapedotomy and left in 2005. You see the left side's got a pretty significant conductive deficit, recurrent conductive deficit. So how would you approach it?
So only one side had surgery, correct?
Yeah, just the left.
Okay. I would offer him the standard thing I would do for anyone who has conductive loss related to otosclerosis. I'd always offer a hearing aid trial first to see if they might want to try that without the risk of surgery. I think he should benefit because his discrimination score is 92%, although, yeah, he'd need a very powerful hearing aid to hear well. I think it would probably help. And I would also consider offering him a revision surgery.
Would you do the revision side before you did the new side?
In his case, since it's the worst hearing ear, I probably would go for that. If they're equal, I'd probably consider doing the other side, provided he didn't have significant problems with dizziness after the first side.
He didn't.
Okay. Yeah.
So Cliff, what would you do?
Yeah, I'd probably do the same. I think obviously exhaust hearing aid options and then discuss a revision in the left side with the understanding that it's depending on what you knew about the previous, if you did the surgery or somebody else did the surgery and sort of what the time course was of the change in hearing and so forth. I'd be a little more optimistic if they had a good result initially and then it went down. Otherwise, with that amount of cochlear otosclerosis, I wouldn't be too excited about what I would find when I looked in his ear anyway. It's just because there may be so much distortion of landmarks and so forth. So, especially if there's a dislodged prosthesis, which is the most common thing.
I think that's a very important point. So, first of all, did you do the staping surgery the first time? If not, you really don't know what's in the middle ear when you go in. Even though it was 2005, you kind of have a baseline. Number two, do you have an audiogram that shows that he actually improved to any significance after the first surgery? So Gavi, if this guy had his left ear operated on, again, it's been 16 years ago, and back when Brandy could actually see, and I had blonde hair actually is when this happened, he only got, say, 50% improvement on that side. Does it change how you manage him?
And I'm just curious, can we scroll through? It would be no, we can't. We can't.
No, this is Stump the Chump, and you're on the podium.
See you down now. The 15 or 50.
What would you be looking for if we scrolled?
I'm actually curious if the prosthesis is even in there or if it looks. Yeah.
And prosthesis is a good position.
It is.
Yeah.
So one other thing would be if you want to look at the round window. So if you have obliteration of the round window, then surgery is not going to be a good option.
So if they didn't get that much of an improvement right away and then it dropped even more, one thing is that perhaps the stapedotomy was too narrow and maybe they never really got great movement of that prosthesis in there, and that might be a relatively successful revision, for example.
So Chad. So let's say you do a stapedotomy, in your thinking, you're saying, if I do a stapedotomy and I get a perfect outcome. Let's say you close the air bone gap on the left and you operate on the left side. How are you still going to manage this person's hearing? Because he still has moderate hearing loss.
I wouldn't operate on them, honestly. I would probably encourage hearing aids and especially binaural hearing aids do much better in noise suppression these days. The other thing I would also consider is bisphosphonate therapy, given the double ring sign around the cochlea, and protecting against any further sensorineural loss.
So he had a revision left stapedotomy about a year later, and that's what we got. A little bit better, got about 50% back. Prosthesis seemed to be in good position, but replaced it, put it in, and he had a right stapedotomy. On the right side, he had a biscuit foot plate, and this is his overall hearing outcome. Okay, that's a final audiogram after all of his surgery was completed. And interesting, if you go back and look at the bone line was lower on the first audiogram than it was after we did the stapedotomy. So, Cliff, what do you think about it? I mean, do you think it was artificial? Was the bone line good?
Not sure. With that, obviously it looks like it's the previous audiogram looks like it was kind of from the Dark Ages, so presumably there was a big interval between the audiograms. I always worry a little bit about any kind of masking issues.
1 year audiogram, 1 year between.
Oh, okay. You worry a little bit about masking issues, potentially, when you have that kind of a mixed loss initially.
So does it rethink how so how are you going to manage the patient now? Is this because you still, and I guess what would be the threshold, Gavi, that you would use to say, the conductive loss is a little bit too large for the patient to be successful in hearing aids? I mean, how far can hearing aids go with a big conductive loss?
Yeah, I think especially that the significant conductive loss in the low frequencies, I think, is challenging for the amplification. So that may be somebody who, you could try it, but, and sometimes you can get reasonable results with the hearing aid with even with the conductive loss, but may or may not be satisfied. I think it's reasonable to try. I don't think that you say, oh, don't try a hearing aid because you're not going to be happy.
Right. So, Brandon, what do you do with them now? Comes in and said, my hearing aids suck, still can't hear, I'm not dizzy.
So this is an osseointegrated implant panel, so I certainly think it's reasonable to do an osseointegrated implant evaluation. And now there are multiple options. There's the fully implantable device with the external processors. There's 2 of those. There's the obviously transcutaneous devices, which are the oldest version. And so you have a number of options available to them, and I certainly would refer them for evaluation to that and see if that's something they would, if it helps them. And then the nice thing is, at least in a lot of cases, that while hearing aids are not covered by insurance, at least at present, osseointegrated implants and bone conduction implants are covered by insurance for the most part.
Yeah, so the insurance coverage is variable. Unfortunately, we don't always have very good success with getting osseointegrated devices covered. But what I sometimes do with these people is just to kind of see what their potential is with a bone conduction device, is have them try some of the bone conduction headsets. So I have a lot of patients actually who really like those because they can still use them with their phone. They can get a lot of function out of them, or even apps you can use on your phone to use as a remote microphone. So it's kind of an inexpensive way for them to try to see if that gives them some benefit. So it gives them some ideas about the potential for a bone conduction device, I think, with little investment on their part.
So who uses fluoride with patients in otosclerosis? Chad, you mentioned it. What's your dose and what's your indication for fluoride?
I do not use fluoride. There were some recent reports that really questioned the research methodology. I don't remember the exact, but I don't use fluoride.
Anyone use fluoride? So I'll actually use fluoride when people start getting a bit sensorineural component. And one of the indications for fluoride in conductive hearing loss is if you want to make them so constipated they forget they have a hearing loss, you put them on fluoride. But how often on a panel, just who when you get a standard conductive hearing loss, who would get a CT scan? Who images those? Go ahead, Brandon.
So if they have absent reflexes and their history is kind of more consistent with a otosclerosis patient, like onset in 20s, 30s, 40s, slowly progressive hearing loss, family history, and they have no vestibular symptoms, I usually will not get a CT scan on that. But if they have obviously intact acoustic reflexes or kind of sudden onset conductive loss, and the story just doesn't fit, then I'll image them.
Why are you imaging them?
So I want to make sure there's not an in-ear or third window, and obviously look for other causes of conductive loss, whether it's like a we've all seen patients with who've had a remote history of an otitis media, and they end up with an ossicular discontinuity at the IS joint or the stapes or those areas.
So it's very interesting. So the third window affection, everyone thinks about semicircular canal dehiscence. Enlarged vestibular aqueduct can give you conductive hearing loss. A posterior semicircular canal dehiscence can give you a conductive hearing loss. So really look for third windows when you do it, and look at the film yourself. So Cliff, how often do you operate? So say somebody comes in, you get a CT scan, they've got a dehiscence and a conductive hearing loss. Would you ever operate on them based on the conductive hearing loss, or for superior canal dehiscence, do they have to meet certain criteria for you?
I wouldn't operate for the conductive hearing loss, even though the outcomes for that are pretty good. I typically would not. There are occasional cases where I would say most people, when they have adhesins, don't actually want surgery when you go through what the details are and the risks are and so forth. In my experience anyway, it's the people that have debilitating dizziness symptoms. Occasionally, if they have really debilitating autophony or hyperacusis, those people, they're wearing an earplug all the time. They're really kind of isolating themselves and so forth. I think the success for the surgery in those people is good, so I will occasionally offer it to those folks, but I would say most decline surgery when they kind of understand what the problem is and they realize it's not dangerous. So,
Brandon, do you operate on people just for hearing loss with their canal dehiscence or third window?
I try to avoid it. I mean, and they have to, and I wouldn't obviously go just on the CT scan. You want to make sure that there are other indications that, because you can have the volume averaging on the CT scan can overcall dehiscence, so I like to have some other piece of evidence, either an air bone gap with intact reflexes, a VIMP study that shows reduced thresholds either on ocular or cervical VIMPs with increased amplitudes. You want to have, or an ECOG that's elevated SP-AP ratio. You want to have some other evidence other than just the CT scan that confirms that there's an actual dehiscence before you even consider discussing treatment. And again, for just conductive loss, I would probably try to convince them.
So VEMP, of course, is vestibular evoked myogenic potential, and ocular versus cervical. A lot of people are actually now favoring the ocular VEMP, thinking it's more indicative. And I think it's a very important point. A lot of people say, well, I'm going to do a VEMP to make sure it's a symptomatic canal dehiscence. And I'm not sure even a VEMP that's consistent with superior semicircular canal it makes it a symptomatic dehiscence. I think the history does. Right. Do they have autophony? Do they have other things? And what I tell them is, I have kind of a standard soundbite I give patients. I said, if I take a CT scanner to Alderwood Mall, which is up north, and I scan everybody that walks in the Apple store tonight, I'll find 5 of these, and they don't even know they have it. Because what ends up happening is that superior canal dehiscence is something you're born with. The dura is nice and thick, and then as people get older, it tends to show up in women earlier than men. The dura thins and it becomes more of a drum than a seal. The real question is, nobody how people perform with advanced otosclerosis and an osseointegrated device. Do they perform differently? We don't know. Is there more stiffening of the basilar membrane? Are there things we just don't know? With superior canal dehiscence, nobody's done a study that says a bone-anchored device is going to close the air bone gap on someone who has a third window. I've never seen a paper on it. But what we do is we send it back to the audiologist, much like what Cliff's talking about. There's these demo models you put on their head, and you say, do you hear better? And that would be probably the best indication of whether you think they're going to improve with an osseointegrated device. But let me take you through and take the panel through a couple of slides. There's a group that was put together internationally, and there's about 8 of us now that meet about 3 times a year, and we're just going completely through the chronic otitis media literature to challenge this concept of the timing of when you would go to an implantable device versus continual use of tympanoplasty and ossiculoplasty. And I think part of what's driving it is people understand that in chronic otitis media, a safe ear is extremely important, and you can't jeopardize cholesteatoma management to preserve hearing because it's going to come back and haunt you. I would say that, I do a lot of revision surgery, as I'm sure most people up on the panel do. I get a lot of people that have cholesteatoma in their zygoma, cholesteatoma that goes up into the calvarial plates above. So when you're doing your cholesteatoma surgery, really make sure you eradicate all the cholesteatoma out of the mastoid and drill into the zygoma to make sure that you're not missing it. So when you look at the World Health Organization, it's very interesting that half of the global burden of hearing impairment, which is literally trillions of US dollars a year, is related to chronic otitis media. And if you went to a panel and asked, what is the clinical best practice? What is the standard way to manage hearing loss in chronic otitis media? If you had 9 panelists, you'd get 12 answers. And I think part of that is the disease is different in each person who has it. But there's really no framework to make that decision. And so this group of people was all put together. Really fun to be on it. Because of Zoom, we can actually meet more frequently. It was way more fun when we were meeting in Europe and eating good meals and swapping case stories and so forth. But you got representation from basically every region of the world. And the reason this was put together is that chronic otitis media is different in different areas. Something that I'll throw out to the panel, I always talk to Alex about when we're getting ready to do a case. I say, I always kind of look at the nationality of the patient on the way in. And there's certain groups of people in our area, and in any area where you live, you're going to have populations that are more apt to have more difficult chronic ear disease. In our area, it's Native American people, very tough ear disease. Native Alaskans, very tough ear disease. And a lot of the refugee populations, the Somalians, I've noticed in this area. Have you guys noticed anything that kind of clicks up the hair on your earlobes to say, I got to think a little more seriously about this?
Just, yeah, with the, we have a large immigrant population and a lot of people who are coming in probably with 20, 30, 40 years of draining ears coming in and basically never been cared for. And I feel like I very quickly learned that those ears do not reconstruct well. Even if you strip everything out and you think it looks really good at the end of the case, when you come in for a second look, the entire middle ear is filled back up, and basically the reconstruction, you can't reconstruct a hearing, I find. Or certainly not get a satisfying result.
And I think it's kind of fascinating that even, I mean, I consider myself a reasonably intelligent ear surgeon, and I'm blown away how many times I get into an ear and it's not what I thought I was going to find. Even when you look at a CT scan, Brandon, you've got a large population of people from,
So we have a large Central American population in Texas. We have some population of kind of East Africa, like Ethiopian population. I see those patients with some frequency, and whenever I see them, I'm like, okay, it's a different animal. I mean, so yes, deal with that all on the routine.
So I do like most people up here. We do very complex neurotology. There is nothing more difficult than getting a Filipino person's ear to heal properly and hear with a good air bone gap. And you could probably say, Colombian, you could probably say Somalian, but pay attention to that, because an ear is not an ear, and it's genetic in some people, plus is it neglect early in life? I mean, we don't know, but in my experience, the Filipino ear is typically a less deep middle ear space. So it's much harder to deal with. And so we actually calculate that into our thinking. So, and that's really come out of this group. I mean, particularly in some of the South American areas, they're saying like, look, a Chilean ear is not like a Peruvian ear. Like I see a Peruvian ear, I refer to my neighbor, so it kills all my research outcomes. So anyway, we did a systematic review of all the literature, and it really boiled down to about 39 studies. And this is pretty typical because, to be blunt about it, most of the otologic literature sucks. But it came out with 39 papers that were actually reviewable, and the complication rates varied from 0%, and I'd love to meet that surgeon, to 47.1%, I would never want to meet that surgeon. And also, part of the complication rate variability is because there's no definition of what a complication is. Some people said, my ear drained for 3 weeks after surgery, and called it a complication. Other people got a dead ear and said that was an expected outcome. So kind of variability. So part of what this group is doing is, what is a structure that you can actually report so that you can read one study and show that it's good as the other study. 14% of people had a complication related to their otologic function, and about half of those were recurrent tympanic membrane perforations. But the air bone gap, 71% of these patients, all comers, close their air bone gap to within 20 decibels. 20 decibels is actually a pretty good air bone gap for a lot of chronic ear disease. If I have a 20 dB air bone gap, I'm probably not hearing half of what's going on in television. So again, a 20 dB air bone gap, to me, I usually draw a line about 25 to 30 decibels where I start warning people that a hearing aid may be more difficult to use because it's going to give feedback, it's going to be difficult to amplify. 30% of patients were reported as did not get a good hearing outcome. That was the outcome, didn't get a good hearing outcome. And that ranks right up there with the neurotology panel I was on facial nerve dysfunction. And one of the Germans closed every case by saying, her nerve came back and she wears makeup. So apparently if you were a female and you have an acoustic neuroma and you wear makeup, you don't have a complication. And I say that in jest, but that's how some of this literature actually reads. There's just no standard. So in conclusion, tympanoplasty, if people were getting isolated tympanoplasties, 71% of people got within 20 dB ear bone gap. You start throwing in ossicular discontinuity secondary to cholesteatoma, recurrent surgery, that number escalates pretty quickly. So one of the issues that this group is looking at is now we have these osseointegrated devices. Are they more cost effective? Every time you take somebody to the operating room, it costs more than it costs to put a device on them. And if their issue is they want to hear the best, is the best way for them to hear a 0 dB air-bone gap. And when you look at some of these osseointegrated devices, they're actually boosting some of the sensorineural levels up to 10 to 15 dB. So, and these devices are getting really powerful. So Brian, now that you've seen the study from the group, how do you think about it?
Well, I've never really been a big fan of the Baja. I've seen a lot of patients with skin issues and stuff, but I think, yeah, if the patients hear better and figure out a way to do it in a way so that there's not as much that kind of a problem, I think I would probably do more of them.
Yeah. Gavi?
Yeah, I wonder also if there's a sense of, to be a successful otologist, or, you're supposed to be able to get these great results with middle ear work. And I think maybe part of it is also just changing how we think about what is the success, and maybe the success is more just how the patient can hear. For me, my issue right now is, as Dr. Hume alluded to, is that it's just there's so many patients I would like to do it on, and I just cannot get anybody approved. So
it's really interesting because we don't have an approval problem.
Yeah.
And we deal with the same insurance companies. And it's really bizarre, and I think a lot of it's the relationship with the insurance companies that we talked about. One of the things you talked about, Cliff, that I find very effective, I tell patients who struggle with significant conductive hearing losses, and some of these folks, you can't get their ears to stop draining for months. I have them go buy those skull candy behind the ear things with a little clip on them. And I mean, they come back and they say, forget about surgery, I'm just going to use my skull candy. So we have these things they can buy over the counter that can actually give them pretty high fidelity sound. So we'll do one more case here. This is a 55-year-old female, left-sided hearing loss. She had a stapedotomy done on the right side a year before, and that was her outcome on the right side. She wanted to have a left stapedotomy, and so when you're looking at somebody, what magnitude, the question for the panel, anybody can answer, what magnitude of conductive hearing loss will you tackle? And what do you tell them about, so one side went really well, how much of a difference is this patient going to note? And do you value the tuning fork? Those three questions.
For something like this, I would, the tuning fork kind of part of my criteria to kind of determine whether someone's a candidate for a stapedectomy. So if they have a conductive loss, but their air conduction is still greater than bone conduction, I would tend to delay or recommend a hearing aid. And I always just recommend a hearing aid as a option, initial option for a conductive or mixed loss related to otosclerosis, or it's always an option basically. And I tell them in this situation, you have your bone line in the high frequencies is not normal, and so even if we have a perfect result, you're still going to be missing some information there. And so a hearing aid is certainly a very reasonable first step for mixed hearing loss.
Chad, what do you think?
I think that patients with conductive hearing loss, purely conductive, are entirely different than any patient with sensorineural hearing loss. And any patient that is reporting difficulty hearing and noise, I think you have to treat that aggressively to basically preserve long-term neurological function and cognition. So I would very strongly recommend a patient get a hearing aid in this case, since they're likely going to need one soon anyway.
Gavi, do you put everybody through a hearing aid trial before you operate on them for conductive hearing loss?
Yeah, for sure. Yeah, I just tell them, if you were my family member, that's what I would do, and if it was me, that's what I would do. So
what we have in our clinic is, if most of you have hearing aid dispensaries in your offices, right? You can go to the hearing aid companies and say, we need 3 demo hearing aids for our clinic, and if they say, well, we really can't do that, I said, hey, Oticon looks better, and they'll give them to you. Dennis is crawling right now, but we actually have loaner hearing aids. We send them out for a week, and we tell them, go to Starbucks, go to the mall, go to church, and see what it's like. And so that gives an indication of what they can do. The other thing I tell folks is that if you have a bilateral conductive hearing loss, your first ear is like an aha moment when you get the improvement. The second ear is you're going to the prom, but you realize your date is your brother. Okay, your hearing's better, but it's not like, wow, I just won the lottery. And for me, it's if the patient flips a 512 tuning fork, that's kind of my threshold. Unless I really get pushed. And I think as you get better at stapes surgery, you can do better surgery and you can improve these things. But even doing that, you got to remember, most of your struggle, and listen to what they're telling you. If they tell you, I've got this hollow sensation in my ear, I can't really appreciate music very well, that's more low frequency. If they're telling you that they can't understand what's going on in a crowded room, your stapedotomy is not going to help them here. So what I'd like to do, if it's okay with the group, is we had planned a break for now, but since we kind of had